Good afternoon or morning to you all. I am Dr. Oliver Brooks, the 120th President of the National Medical Association and CMO at Watts Healthcare Corporation. Thank you for joining today's webinar, COVID-19, an update. I am based in California. We have faced a grave threat with wildfires. There are 5 parallels that I find frame well what we are facing. 1. COVID-19 is burning through the nation. The first responders, this time the healthcare workers, along with the standard fire and security workers, are at the highest threat. 2. COVID-19 will not be extinguished by our efforts. It will only be contained. The response from the greater community will be what limits the overall scale of human tragedy. And a wildfire escaping. In this pandemic, the opposite, sheltering in place. 3, the catastrophe will end. In a wildfire, it is when there is no more flame. With COVID-19 is when there are no more cases, or at least a great diminution. Number 4, when we look back, there will be a trail of destruction. In a wildfire, a ravaged landscape with fatalities. With COVID-19, a ravaged economy with fatalities. And last, number 5, in the end, after a wildfire, the forest recovers, people rebuild. With COVID-19, the economy will recover. We will rebuild our lives. There is life after disaster. We are a resilient people. Our sole purpose as healthcare providers and citizens is to mitigate the damage from COVID-19 and heal the scars that will inevitably be present after this ends. Also, we must take into account the disparate effect on the African American physicians and our community. Right now, we are in the early stage of what I am labeling phase 2 of COVID-19. Phase 1 was the preparation for the COVID-19 attack. Phase 2 is the battle. The battle is on. Phase 3 will be the aftermath. We are not there yet. To get a picture of this phase 2, the COVID-19 attack that we are facing, I have assembled a stellar panel of national experts. Dr. Jerome Adams, the 20th Surgeon General of the United States, will give us the national perspective and response. Dr. Patricia Whitley Williams will provide the clinical perspective. Dr. Georges Benjamin will inform us from a public health and epidemiologic perspective. Dr. Sonia Hutchins will give us information on a somewhat overlooked side of COVID-19, our own and our community's health and well-being during a pandemic. I will begin with Dr. Jerome Adams. Dr. Jerome Adams is an anesthesiologist and a vice admiral in the U.S. Public Health Service Commission Corps, who currently serves as the 20th Surgeon General of the United States. Dr. Adams was confirmed by the United States Senate on August 3, 2017. As Surgeon General, Dr. Adams oversees the operations of the U.S. Public Health Service Commission Corps, which has approximately 6,700 uniformed officers who serve to promote, protect, and advance the health and safety of our nation. In the interest of time, the Surgeon General has asked me to forego the rest of his extensive CV to allow for time for more discussion. I am honored to present to you the Surgeon General of the United States, Dr. Jerome Adams.
Well, good afternoon, everyone. Thank you to the NMA and to Dr. Brooks for hosting this very important phone call and for letting me be a part of it. I have a limited amount of time to update you, but I know that many of you don't know me, and some of you, quite frankly, don't have a lot of trust in me or in this administration. So I want to take just a quick moment to give you some background about me and where I come from. I grew up in a rural, mostly white Southern community. I benefited from WIC, reduced lunch, and other government assistance growing up. All 4 of my grandparents died prematurely from chronic disease. Many of you know my brother is incarcerated due to his addiction. My mother had a major stroke just a few months ago, and I myself am currently on 8 different medications being pre-diabetic, hypertensive, and asthmatic. I know what it's like growing up poor, Black, and with minimal access to health care. And I personally am experiencing the lifelong impacts that stem from that. I don't affiliate with a party, and I didn't take my current job for political reasons. My kids say, Dad, how come you keep taking more and more important jobs that pay less and less money? The fact is that, like many public servants, like all public servants, we've sacrificed to try to serve our communities. I'm a Christian, and I believe God doesn't put you where you'll be comfortable. God puts you where you are most needed. The fact is, our issues as people of color are too important to go 4 years without representation in the highest levels of government. I'm going to say that to you one more time. Our issues as people of color are too important to go 4 years or 8 years without representation in the highest levels of government. And I have faith that God has put me where I'm most needed. That said, I spent my life fighting and will keep fighting for the poor, the disadvantaged, and people of color, and I will continue to work to earn your trust. That's not by what I say, but by what's done. And just so you know, I was the highest and I think the only administration official who was at the NAACP annual meeting last year in Detroit, and as well as at the NMA annual meeting in Hawaii. I've worked to highlight infant and maternal mortality, the opioid epidemic, smoking, and dangers of marijuana use, all which disproportionately impact communities of color. But again, I'll keep working to show you that through my deeds and by showing up, I'm fighting for you and your patients. Now on to coronavirus. The WHO declared the situation a global pandemic 2 weeks ago, and now over 150 countries have spread. The U.S., and in particular New York, has become the global epicenter. Initially, when most of the infections were coming from China, we engaged in what we called containment efforts to keep the disease out. And most experts actually feel that that did, in fact, work to slow the spread. And the problem was Europe didn't close itself off to China, and cases spread there. Italy became the new Wuhan, and then Italy and the rest of Europe are what actually seeded most of the rest of the United States. When you do tracing of contacts and genetic tests, you go back, most of the cases in the U.S. Initially came from Europe, not from China. Now that all of our states and most of our territories are reporting cases, we've shifted to a combined containment and mitigation strategy. Containment meaning keeping cases out of your community when you can, along with aggressive case contact tracing of new cases, and mitigation meaning in communities with internal spread, we limit the impact within those communities so that we don't overwhelm the healthcare capacity. And that's what we talk about when we say flattening the curve. That relies on social distancing and protecting our most vulnerable. Over 100,000 Americans have been diagnosed and over 1,000 have died. And we're at a critical point in terms of determining if we can limit infections and decrease deaths, like we've seen South Korea and China do, or if we go the way of Italy and now New York, which has seen skyrocketing infections and deaths in many cases, because when you look at the data, they were late to apply mitigation after they saw a significant upspike in cases. And I was looking at the data this morning. Both New York and Italy saw a doubling of cases for several days, almost a week, before they really started to lean into aggressive mitigation strategies and then ultimately deciding to go to a complete and total stay-at-home. We had an aggressive and early travel restriction and quarantine policy for China because, again, that's where all the cases were at first. That bought us some time. Initially, Europe and especially Italy again ceded the U.S. cases. The U.S. as well as most other developed countries now have global travel restrictions to keep new cases out. I want to be upfront with you all. Testing has not gone as well as we would have liked to so far. There are many reasons for this, and I'm happy to take a question on it if you all would like. But the plain and simple fact, and you all know this as healthcare providers, for better or for worse, and I'm not saying either way, but it's just a fact, most of the testing and healthcare supply capacity in the United States lies in the commercial sector. The CDC was never designed to go out and test 300 million people. It was designed to respond to sporadic and regional outbreaks. When you look at the National Strategic Stockpile, they purchase 0.1% of all the medical supplies in this entire country. That means 99.9% of the supplies, the capacity, the distribution chain, et cetera, lies in the commercial market. So our strategy has to be using the CDC and the strategic stockpile to respond to hot spots in places that are overwhelmed or need it the most, but while also empowering the commercial market and healthcare systems regionally to continue to do what they've been doing all along, and what in many cases we as doctors have fought for the right to be able to do, to keep that decision-making and authority at a local level. From a testing perspective, I want you to know that we truly have turned a corner, and that's not just words, that's numbers. We're approaching 100,000 tests done per day. And yesterday, the FDA approved a point-of-care test that we're told we will soon be able to test another 50,000 people per day with. More importantly, that point-of-care test will give us results in under an hour, which will allow us to take a more precise approach to patient care and public policy, a scalpel instead of a chainsaw. Also on testing, important to know that people put South Korea up as the model for mass testing. They tested about 1 in 200 people in their initial surge. If you do the numbers, that would equate to about 2 million people here in the United States. We are about at 1 million, and within a week or so, we will be at 2 million. So we are approaching mass testing numbers, and that's important for people to understand in terms of keeping things in perspective, because everyone says we can't figure out what to do unless we do massive screening. We are beyond most other countries at this point in terms of total amount of tests done and in terms of ramping up testing. And we are, in fact, getting some good surveillance numbers from many places. We likely will never get, there's never been a test in the history of this country where we said we're going to test 300 million people within a few weeks to a few months. Surveillance testing is really about getting enough of a sample so that you understand what's going on in your community. And we are rapidly getting to that point. We're still prioritizing testing for healthcare workers and for those who are most vulnerable, people over 65 with underlying medical conditions. But it's important for people to know that even in South Korea, where they had a severe outbreak and tested large numbers of people, 96% of symptomatic people tested negative for COVID-19, and over 99% who did test positive ultimately recovered. Our numbers aren't quite that high in the United States because the sickest people present first, but still in the U.S., over 90% of asymptomatic people who are tested, especially outside of New York, are testing negative for COVID-19, and the majority are recovering. In other words, even if you're sick with fever, cough, and shortness of breath, it's statistically probably not COVID-19. And even if you are in that 10% for whom it is COVID-19, if you're in a low-risk group, you will likely have only a mild illness. Now, from a demographic point of view, we are seeing younger people affected and hospitalized here in the United States than in other countries. We're still trying to figure out why. We don't know exactly why. It may be because many of our young people actually vape. And you all know hopefully you know I put out an advisory last year about the number of our young people who are vaping. It may be for another reason that we're seeing this occur. But still, when you look at the data, the significant increase in people who are hospitalized, ventilated, and who are dying is people over 65 with underlying medical illnesses. I also don't want young people to think that this means we shouldn't all take precautions and practice social distancing. And it doesn't mean that even if you test negative for coronavirus, you should be going out into public. Because if you've got a cough and a fever, you probably have an infectious disease, and you don't want to be spreading it to someone else. And even if you are at low risk, you don't want to be the one who gives it to your granddaddy or your nana. I also want to talk about coronavirus in the Black community as I finish. At first, there were widespread rumors that Black people couldn't get coronavirus, and I put out several tweets saying, oh, yes, you can. Now there are rumors that Black people can't get tested for coronavirus. Neither of these are true. I told you about our testing priorities, and that was because we wanted to prioritize healthcare workers and the people who were most likely to get sick and die first as we were ramping up testing. I want you to know that those with underlying medical conditions are at greater risk for being asymptomatic, hospitalized, and dying from COVID-19. And unfortunately, Black people are more likely to have those underlying conditions: heart disease, lung disease, diabetes. And as you've heard, I have all three. So if anything, we need our communities of color to know that in many cases, we are at higher risk for complications of COVID-19 than the general public, and we therefore must protect ourselves and our communities. I also want you to know we've been working hard on the 3 bills that came through Congress that, among other things, provided food and nutrition assistance, unemployment assistance, and paid sick leave, put a pause on federal student loan interest and HUD payment, and soon we'll be sending checks for thousands of dollars to many likely most families of color in the United States. There is a robust debate about what's best for the health of the economy versus the health of our people, but it's important for us to understand and articulate that these two cannot be disconnected. We've all been out there talking about the social determinants of health. We know that wealth is health and health is wealth. The fact is, if you can't pay your rent, put food on the table, or can't care for your kids because you can't work, then for many of us, that's going to be as harmful as coronavirus. And no one knows that better than communities of color. In fact, I bet that if before yesterday's bill signing, and perhaps even after, if you polled working Black Americans and asked them if they'd rather lose their job or take their chances with coronavirus, a good number of them would say, I'll take the coronavirus. I don't want them to have to make that choice. And we're working hard to protect their physical health and protect their livelihood. And again, it's important that people understand that we have to do both. My Surgeon General's prescription for America involves three things. Number one, know your risk. Know if you or the people you love are in those highest risk categories, over 65 with chronic medical conditions. Number two, understand and control your circumstances. Particularly understand what spread is going on in your communities, and avoid higher risk and large gatherings, traveling in communities where you're seeing hotspots and where there's widespread. And number three, get the facts to protect yourself. The two best places to get the facts are your State Department of Health website, because they're going to have local numbers, local statistics, and they'll let you know about local mitigation strategies, and then coronavirus.gov. Check out our 15 days to stop the spread recommendations at coronavirus.gov, including avoiding gatherings of larger than 10, avoiding unnecessary travel, and staying home from work if possible, which more people will be able to do now because of the bills that were just passed. I know other speakers are going to talk about this, but I want you to know I am deeply concerned about communities like New Orleans, Chicago, Detroit, Indianapolis, LA, and Miami. In the next week or so, the fact is they're going to have a rapid surge in cases similar to New York last week. So if you're in those cities, start preparing. Start figuring out where your excess capacity is, because when we look at lessons learned from New York, in many cases, you had a hospital in one part of the state that was overwhelmed, while you had a hospital in another part of the state that had a low census because they pulled down elective cases. Which leads me to another thing. You need to be saying in every hospital, wherever you are, people need to stop elective cases, because I have several tweets about this. I have an op-ed about this. It does a number of things. It uses PPE that's pulling from the national stores. 3M only makes so many masks. And even if you don't have problems in your community right now, if you're pulling supply from 3M, that's supply that can't go to Miami or to New York or to Seattle or to Chicago. So it pulls from the national supplies. It stresses our healthcare workers. And it also, every single person who comes in the hospital unnecessarily is potentially bringing coronavirus into that hospital. And we know that when people come in for elective surgeries, they don't come in alone. So let's just say the underlying rate in your community is at 0.5%. If that's the case, then that means every 200 people that come into your doors unnecessarily is someone who could be asymptomatically bringing coronavirus into your hospital and putting you at risk and your patients at risk. We need to stop elective surgeries, and I'm still hearing way too many people are doing it, even though I put out a tweet, put out an op-ed, and we put out calls from the podium at the daily briefings telling people to stop. And encourage your policy leaders to get serious about mitigation and shelter-in-place orders based on the data. Unfortunately, again, we've seen it play out in a couple of places. Folks wait too long before they lean into those shelter-in-place and mitigation efforts, and that causes their curve to extend longer than what it has to. We actually have seen, and here's the good news, China's reopening, South Korea is reopening. We've seen Italy's cases level off. New York's cases, the acceleration is slowing down. It usually takes about 2 weeks from the time you go to shelter-in-place and aggressive mitigation after you see a wide community spread for you to see the impact and the leveling off. Why? Because the incubation period is 14 days, and we know it's going to take about a week to 2 weeks before the cases that are infected now end up in the hospital. So that means if you see widespread today and you wait a week, that's a week you've lost. The people are going to continue to come into the hospital for a week to 2 weeks after you put in those mitigation efforts, because it takes that long for the symptoms to actually develop. So it's important that we do that early. It's important that you talk to your community leaders early. In the midst of community mitigation efforts, I also want to ask people to connect more deeply and more often, even while they're physically more apart. It's easier to do this than ever before with FaceTime and Skype, or even check in with a text or a call. Connection can keep spirits up and give people strength to fight a national threat. We know in African American communities and communities of color, church is a great place for people to get that togetherness. But unfortunately, in most communities, church proceedings have been pulled down. So again, we need to think about how we can connect with people and keep them connected. You can establish a buddy system to ensure vulnerable and hard to reach community members stay connected. So I just want to finish there and say thank you for your interest and support of this response. It's going to be a tough several weeks ahead. The fact is, things are going to get worse before they get better, particularly in different places across the U.S. But there is some promising news in that testing is rapidly increasing so that we can do more informed policymaking and patient care decisions. There's good news because we've seen that when people lean into mitigation, we can typically hit our peak and start to come down in about 2 to 3 weeks. So we do see some light at the end of the tunnel there. And again, I just know that if we really see this as a locally executed, state-managed, and federally supported response, the way our healthcare system has always been set up to be, and then save the federal government resources for the places that get overwhelmed and most need them, that we will get through this successfully. So, Dr. Brooks, thank you so much for the time. And again, I'm happy to take a couple questions if I didn't run over too much.
All right, no, that's fine, Dr. Adams. A question came in. Can you speak to the food safety of the United States? And I believe it's not in terms of the amount of food, but just the overall safety of consumption of food in the United States at this point.
That is a great question. And what we have told people and what we've seen so far is that the novel coronavirus can live. The best information we have on it, we're learning every day, comes from our experience with other coronaviruses. And I think you all know this, but the common cold is a coronavirus. MERS and SARS, we have some experience with them in general, even though this one is behaving somewhat differently than past coronaviruses. And if it's something that you're going to eat cold, if it's a fruit or a vegetable, wash it off. We feel like the food supply in general is safe for people as long as they take normal precautions. We know that, like other coronaviruses, this one is sensitive to both extreme heat and extreme cold. And but we do know it can live on surfaces for anywhere from hours to days, depending on the surface. Now, I don't want to scare you all, because when they do these studies, some of them are looking at RNA, which can be found on surfaces even when it's dead. So when they looked at the Princess cruise ship, they found coronavirus, and I'm doing air quotes here, days after they had cleared the area, but that was RNA, so that could be dead coronavirus. We also know that when they do tests in labs, they're spraying highly concentrated virus into areas and then looking for it. So none of those replicates the what we'd see in the public, but in general, take normal precautions, wash your hands. I went to the grocery store this morning. What I tell people when you're going to the grocery store is to make sure you wash your hands before you go in, get your groceries, taking care not to touch your face, because we're actually getting increasingly concerned about surface transmission, taking care not to touch your face. As soon as I left the store, I made sure I put on hand sanitizer. I brought my groceries home and wiped them down with a wipe, or I'll spray them with Lysol and let them sit for a little bit. And then I just use them like regular food. I got a couple of apples and bananas. I washed them off the way I would wash off my apples and bananas and grapes any other time. But we are not at this time thinking that food is a major or significant means of transmission of coronavirus.
All right, thank you. Another question came in. Is there any present role for the military in the response to COVID-19, let's say, other than what we've seen already?
The military is fully engaged. Many of you all know I'm on the coronavirus task force, and I'm leaving here to go down to the White House for a meeting. We actually meet every day, and the military is part of that. Important for folks to know, National Army Corps of Engineers is building hospitals in hotspots. They're building 8 hospitals in New York. They're building hospitals in Seattle and in California. Each state also has a National Guard unit, and we activated Title 32, which means the federal government will pay 100% of that National Guard unit salary and expenses, but they're still under the governor's control. Many of you don't know, I used to run a state Department of Health. And from a public health perspective, most of the authority for a public health response lies at the state level with the governors. So we're really trying to empower the governors and the National Guard to lean into this. We're also sending the Mercy and the Comfort 2 naval hospital ships. One's going to New York. It's taken off today. The other one is going to Seattle, and it took off last week. And so we are looking, and we're also looking at how we can build excess capacity in terms of field hospitals for people in communities that are hardest hit. So yes, the military is engaged. We've got to be really careful about that because everything we do, there's a pro and a con, and people are very concerned about martial law across this country. So we're careful to say we're going to give the local folks what they ask for and need and support them, but we don't want to go to martial law all across the country because that could have unintended consequences, particularly for communities of color.
Thank you. And the last question for the Surgeon General came in. When do you think we'll see signs of flattening of the curve, or what is your perspective on that aspect of our monitoring of COVID-19?
That is a wonderful question, and the most honest answer I can give you is one that Dr. Fauci and I have been saying all along. Everyone's curve is going to look different. So the most important thing is that we've ramped up testing so you can understand what's going on in your community from a surveillance point of view. The second you see an uptick, you want to lean into aggressive mitigation. But the places that don't have an uptick yet, if you do aggressive case contact tracing, the way we do for any other disease, you can keep the numbers in your community low. And we've seen that in places like New Mexico that have actually been doing a lot of testing and have kept their rates low. But if you're one of those cities that's starting to see an uptick, then the first thing we look for is a slowing in the acceleration of your cases. And we're already seeing that in New York, and they're only about a week into their shelter-in-place order. And what does that mean? That means that they were initially seeing their hospitalizations double every 2 days. Then it went to every 3 days that it was doubling, then every 4 days. So they haven't leveled off yet. And again, we don't expect that for another week or so, but they have seen the acceleration slow down. That's phase one. Phase two is when you level off and you get to a place like Italy is right now, where you're still seeing high numbers of cases, but it's stable every day. It's not continuing to increase or double every day. And then you get to a point where you start to see it come back down again, and where you've seen that in China and in South Korea. So it's going to be, some places are never going to go off on a trajectory like that. And we want to make sure we're doing everything we can to make sure if your communities aren't already seeing a rapid uptick, that they don't see an uptick. But other communities are going to have curves like New York and Italy, and we just want to make sure as few people die as possible. And that really comes down to not the government response or the number of ventilators or the number of or supplies. Those are important. Please don't misunderstand me. Those are important, but we can't supply our way out of this problem. It really comes down to how aggressively we prevent that spread in the first place. So I want to thank you all again so much for giving me the time to address you. I want you all to know how much of an honor it is to serve as your United States Surgeon General and to be your voice in the room. And I want you to know your leaders have my phone number, my cell number, and they use it. And so I'm hearing your concerns, and I am trying to be your voice at the table and make sure we're giving you all the tools you need as providers and putting your patients in the best possible position to be healthy. And before I go, I want to say one more thing. It is important that we understand that our reaction to this causes equal and opposite reactions in other areas. You heard me say last week that blood donations were down. So we don't want to put ourselves in a situation where people are dying because they can't get blood because they're scared to go out because of COVID. We know fewer people are getting prenatal care right now, and moms are scared to go into the hospital to have babies. And when they do, they're being told they can't bring anyone in with them. We need to be thinking about these things. We need to understand that the healthier you are, the more resilient and resistant you're going to be to being symptomatic and being hospitalized and dying from COVID. So now more than ever, we need to lean into overall health, mental health. Many folks are separated from their mental health providers and from their substance use disorder providers at this point in time. So we've rapidly increased telehealth and lowered barriers so that you can get fully paid for telehealth services. We need to think about ways we can provide services for people and keep them healthy, because I don't want more people to die from cardiovascular disease or maternal mortality or opioid overdoses than end up dying from coronavirus because we're so scared that we break off everyone's connection with their healthcare providers. So thank you, Dr. Brooks. I appreciate it. And again, reach out to me if other questions come up on the call that you'd like me to address with you. I'm happy to share, happy to do this again in a few weeks. I want to make sure you all are getting the info and the tools you need.
Thank you very much, Dr. Adams, for putting some time aside at this moment in our nation's history. We appreciate it very much. Our next presentation will be from Dr. Patricia Whitley-Williams. She will be presenting from a clinical perspective. Dr. Whitley-Williams is Professor of Pediatrics, Chief of the Division of Pediatric Allergy, Immunology, and Infectious Diseases, and Associate Dean for Inclusion and Diversity at Rutgers/Robert Wood Johnson Medical School. She's President-elect of the National Foundation for Infectious Diseases, the NMA's liaison member for the ACIP at the CDC. She too has an extensive resume. I will stop here. Dr. Whitley-Williams.
Good morning. Thank you very much, Dr. Brooks, for that wonderful introduction. And I'm so proud of the NMA and thank the NMA for conducting this webinar on COVID-19. I'm also very thankful and very proud of our Surgeon General, Dr. Jerome Adams, that he would take time to spend with us this morning or this afternoon, depending on where you are, and thank him for his outstanding leadership. Today, I'm talking about the clinical symptoms and treatment of COVID-19. The three most important symptoms are fever, cough, and shortness of breath. Those are the criteria that are being used for investigating a person for COVID and for testing. These numbers are based on studies that were published as a result of the COVID-19 outbreak in Wuhan, China. Most everybody gets fever. They also have this dry cough that is persistent, as well as shortness of breath. There are some other symptoms that have been reported, such as myalgias, fatigue, and less commonly reported respiratory symptoms, such as a sore throat. Very few have productive cough. And then there are some that present with GI symptoms before the fever and respiratory symptoms are noted. More likely to be diarrhea and nausea or post-tussive emesis. More recently, some patients, it has been noted, are complaining of loss of smell and taste. But realizing, and I think as Dr. Adams pointed out, most patients will have mild symptoms, and based on the published reports, in from Wuhan, China, most people do not require hospitalization and have mild symptoms. The clinical course in hospitalized patients is very striking. A number of patients, maybe about a third, will develop what we call ARDS, or acute respiratory distress syndrome. About 10% will have secondary bacterial infections, whether that's bacteremia or pneumonias. And up to half of the patients who are hospitalized do get intubated and placed on mechanical ventilation. Some of these patients even are managed with ECMO, although very few. Other complications in these hospitalized patients do include multi-organ failure or multi-system failure, including renal failure and liver dysfunction, etc. And the case fatality rate in China in these critically ill patients was 49%, almost half of the patients. So this is very striking. And of course, we're looking at our experience in the US as well. The laboratory and radiology findings, most striking in terms of the complete blood count, is a lymphopenia. It occurred in 63%, and only a third maybe had thrombocytopenia. The liver function tests or liver enzymes were elevated in 37% of the patients. And then in severe cases, almost all of them had elevated biomarkers, and we know those as C-reactive protein, the sed rate, ferritin, procalcitonin. And in those places that were able to measure inflammatory cytokines, these were also very much elevated, IL-6, 8, 10, and tumor necrosis factor alpha. The next slide shows chest x-ray of a typical patient, obviously critically ill, being monitored. But if you, I don't know if you can appreciate it, they often call this sort of a ground glass appearance in the periphery of the lungs. And then there appears to be, there are some infiltrates or consolidations. And then more telling on this next slide is an example, a classic example of what a CAT scan would look like. On the right of your screen, this is a high resolution CT. And again, in the background, you sort of see this ground glass appearance, but then there are definitely infiltrates. These are consolidations, and a very classic appearance of what we're seeing in patients with COVID-19. I won't spend much time on this slide except to say, in the experience in China, there are very few children who were terribly sick, and Dr. Adams alluded to that fact. In fact, there are no deaths reported under 10 years of age. Over 90% of the patients under 18 years of age were either asymptomatic or had very mild disease. And based on the experience that I'm seeing, even though our adult side of the hospital is full of patients with COVID-19, we're seeing very few, and those that we do suspect, interesting, Dr. Adams mentioned this, they actually have had a history of vaping, and it turns out they did have hypersensitivity pneumonitis secondary to vaping and improved rapidly with steroids. So let's move on to the treatment. Let me emphasize that currently there is no approved US FDA approved medication specifically for COVID-19 infection. The main corner of therapy includes supportive care, including ventilator support and supplemental oxygen. However, there are some anti-infectives that have been identified and are being used. So chloroquine and hydroxychloroquine are both oral anti-infectives. Chloroquine is FDA approved, as you all know, for malaria treatment and prevention. Hydroxychloroquine is FDA approved for inflammatory conditions such as lupus and rheumatoid arthritis. There is some in vitro activity that is demonstrated by both of these drugs, medications against coronaviruses, both the coronavirus that was responsible for the SARS outbreak, as well as against SARS coronavirus 2, which is the virus that is responsible for COVID-19. And the mechanism is that they interfere with the terminal glycosylation of the cellular receptor angiotensin converting enzyme 2, which in turn negatively influences the virus receptor binding. Remdesivir is investigational. It is an intravenous antiviral drug. In the past, it has shown promising activity against other coronaviruses that caused SARS and MERS outbreak, but it's also had some activity against respiratory syncytial virus and Ebola virus. The mechanism of activity, it interferes with the action of the RNA polymerase, which results in an early or premature termination of RNA transcription, and therefore the virus cannot replicate itself. Remdesivir is available, and it was published on the clinicaltrials.gov website yesterday for expanded access treatment protocol. And this is being used in the treatment of COVID-19. So it is available for compassionate use as well in persons 18 years and older. The only other access to using remdesivir is through 3 clinical trials. One is an NIH-sponsored, double-blinded, placebo-controlled trial, and the other two are phase 3 randomized open-label trials, which are specifically addressing duration of therapy, 5 days versus 10 days. Chloroquine was identified in the treatment of COVID-19. There was one study in China that seemed to show some both clinical and virologic benefit when used in treating patients with COVID-19 compared to an untreated group. But this has not been repeated. And chloroquine was added as a treatment in patients with COVID-19. However, there is a safety concern, and that is cardiotoxicity, mainly prolonged QT syndrome. Hydroxychloroquine is more widely available in the US, and so that is the drug that has been used in combination with azithromycin. It appears that this drug also has higher in vitro activity against the SARS coronavirus 2. Again, it's the virus that is causing COVID-19. However, the evidence is still based on very limited in vitro data and uncontrolled trials. And so this is being used in an anecdotal use, both in the US, I know we've used it at our hospital, and in China and other countries as well. There are safety concerns, again, for hydroxychloroquine, and that is the prolonged QT syndrome. There are randomized control trials that are ongoing for pre-exposure, post-exposure, and treatment of SARS-CoV-2. But the optimal dosing and duration of treatment is really unknown. There are specific treatment indications. One, these medications should only be used in patients who are requiring an ICU level of care, patients who are requiring supplemental oxygen, and for those who have lower respiratory tract disease, have pneumonia, pneumonitis with risk factors for progression to severe disease. And in that group is included immunocompromised and those patients with severe chronic comorbidities. There are many other medical therapies for COVID-19 that people have tried and have looked at. You may have heard of the HIV medication, lopinavir, ritonavir. Is shown really not to be very effective. It's not being widely used. There's also, we should mention, active and passive immunization. The vaccine trial, as you heard, is starting up. It's in process. Passive immunization, there is an investigational COVID-19 convalescent plasma medication that can be, or a biologic, I should say, that can be used and can be obtained through an emergency IND or investigational new drug. This is used on an individual basis. So when patients who are confirmed COVID-19, they are donating their blood, and then the plasma is being extracted and saved for use in this type of trial. And then there are many adjunctive therapies. There are over 200 studies listed on the clinicaltrials.gov website, attempting to find some therapy or therapies to use in patients with COVID-19, particularly those who are extremely ill. As you can look at the list under adjunctive therapies, I just want to make a couple of comments. One is that steroids are not recommended. They have no effect on mortality. The ribavirin and interferon combination is also discouraged, not only because of the high toxicity seen from the use of interferon, but also because of ribavirin is inhalational and the virus may be aerosolized. So obviously the people who are taking care of that patient are at greater risk. And then there's a recombinant ACE2 inhibitor, which is also in trial, as are many other cytokine inhibitors. I'm going to end here. These are my references, and we will take questions at the end. I thank you for your attention.
Thank you very much, Dr. Whitley Williams, for your information, especially including the clinical findings and the therapies for COVID-19. It was very comprehensive. we will take questions at the end, as she stated, so send them in, please. Our next presentation will be from Dr. Georges C. Benjamin, who will present from a public health and epidemiologic perspective. Dr. Georges C. Benjamin currently serves as the Executive Director of the American Public Health Association, the nation's oldest and largest organization of public health professionals. He is a former Secretary of Health for the state of Maryland. He is a Master of the American College of Physicians, a Fellow of the National Academy of Public Administration, a Fellow Emeritus of the American College of Emergency Physicians, a member of the National Academy of Medicine, and a member of the National Infrastructure Advisory Council. Again, he has an extensive CV, and there is more than I just spoke. I will stop there. Dr. Georges C. Benjamin.
Hello, everyone. Thank you very much for allowing me to spend the day with you. Let me start by just pointing out that this disease originated fundamentally from one of these wet markets that we see here. These are markets where we have live animals and open meat markets together. While this, obviously this particular one originated in China, it's important to understand that these are all around the world. And one of the public health initiatives we all need to do is be working on a global level to try to address these from a public health risk perspective. Because while we have COVID-19 coming from this particular one, we've had numerous outbreaks that have come from these kinds of wet marks. And from a public health prevention perspective, this is really one of the challenges we've got to address in the future. I like to think about this as having three epidemics. The COVID-19 epidemic that we're obviously addressing right now, an enormous amount of misinformation and disinformation as an epidemic. And the Surgeon General pointed that one out, particularly in the African American community, the fact that there were many people that felt that African Americans were not at risk, or were not going to get equal access to care. And we need to work very, very deliberately to make sure that we correct the information that's not correct that's out there, and make sure that all of our patients have adequate access to health care. And then there's this huge epidemic of fear, and fear of the unknown, poor risk communication by a whole range of actors, which has ultimately resulted in an enormous loss of trust throughout this epidemic. The virus is from a family of coronaviruses. We know this virus fairly well in terms of its family. It's one of the many viruses that causes the common cold, along with rhinoviruses and other viruses. We saw it, as you know, early on with SARS-CoV-1, and now it's changed, and now it's SARS-CoV-2. But it's in this family of viruses, and so we know a lot about coronaviruses, but we don't know a lot about this specific strain of coronavirus, which does act very differently than some of the other previous strains of the virus. We know that it is a pandemic, and there's been a big debate about whether it is or not it is. And a pandemic is something that is all around the world, and this is an example of exactly what this is. This is actually an older map. But for those who don't think that it's been involved in the continent of Africa, you can see it clearly has penetrated the continent of Africa, as well as all 50 states in the United States. To show you how rapidly this virus is spreading across the country, it now is in all 50 states and Puerto Rico, the Virgin Islands, Guam, and of course the District of Columbia. As of yesterday, we had over 100,000 cases, and as of this morning, more than 1,500 deaths that have been reported in our country. So this is a rapidly moving epidemic all across our country. What we know about epidemiologically about this to date is that Rho, the reproductive number, which is the number of people that would be infected for every case, is about 2.2. This means that it's more infectious than most strains of influenza, certainly all the strains of influenza we've seen in modern times. And based on the early data from China, what you heard earlier was about 80% of the cases tend to have mild symptoms, with 15 to 20% of them being more severe. This is particularly important because in communities of color, as you heard from both the Surgeon General and Dr. Whitley Williams, the fact is people with chronic diseases to which we're disproportionately impacted are most affected. So while we're not at more risk because we're particularly African Americans, we're more at risk because we have a disproportionate amount of chronic diseases like cardiovascular disease and asthma and diabetes and hypertension to not do well when we're exposed to the disease. Overall, the case fatality rate, we're still looking at it nationally. It depends on where it is, but somewhere between 1.5 and 3.5. And of course, that'll be different in different parts of the country, depending on what their exposure rate is and the fundamental mix of the health status of their populations. Like most of these diseases, we hope that it'll drop as we know more about the number of people who have mild symptoms, but that remains to be seen. And obviously, community transmission is actively occurring. So even those communities that don't have a case right now are still at extraordinary risk. We think primarily it's respiratory spread, and many of the other ways are unclear, but we do know that the virus lives for hours to days on some surfaces. How effective it is remains still to be seen. And a lot of research is being done right now to better understand how this virus spreads, other than particulate spread from coughing and sneezing, or if you touch a doorknob that's recently been infected. Just to give you a sense of case fatality rates with other diseases, again, 1.5 to 3.5 in terms of the fatality rate. The reason we don't want people to compare this to influenza is the fatality rate for influenza is only 0.1%. So you can see this is a big difference between influenza and coronavirus. And such diseases like with MERS and Ebola certainly had much higher fatality rates, but for much different reasons. And I just as a public health guy, I just want to make sure that people realize the reason we push people to get vaccinations for diseases in which we do have vaccinations like measles is that unvaccinated rubeola has a fatality rate of 1 to 3%. And many of you know that is a very, very infectious disease. So we don't have a vaccination for this, but this is an opportunity for us to communicate to people the value of their flu shot, and when this is over, continue to point out the fact that good public health measures around prevention are very important. Okay. So the non-pharmacological interventions, you know, because we don't have a therapeutic option right now, the idea of what we call flattening the curve is a sound and major public health intervention. As you know, the curve is basically a bell-shaped curve, and our goal is to both flatten the curve to give our health system more time to respond, and also hopefully reduce it so that less people get sick. And so we're really actively working on doing this non-pharmacological intervention right now as a major strategy. And that's the social distancing strategy that we're doing. You know, this is just a graph, a nice picture just to give the folks the idea of what social distancing is all about. You know, I think it's an interesting picture, and I think it graphically just displays what we're trying to accomplish with social distancing. And you heard about testing. The Surgeon General talked a bit about the fact that testing is a problem. You know, there's still problems with the test, although it's rapidly becoming more available. And we have a whole range of new testing options that are underway. And we just need to recognize that the testing is one of the essential strategies that we're still going to have to use. We still need to understand where this disease is going, both from a surveillance perspective, which the public health folks are very much interested in, and from a clinical perspective, where the practitioners are certainly much more interested in. And you've heard a lot about the therapies already that are available, and so I won't go much into more detail, only to say that communicating what is safe and effective is going to be very important, because patients are getting a lot of misinformation about what therapies are available. And as you know, we've had one death because of miscommunication around a therapeutic option. I think it's important to deal with this issue around infodemic of fear and misinformation. The way we deal with that is through facts, frequent communication. I don't think you can overly communicate that, and that's particularly in our communities. I don't believe you can overly communicate the facts. And we're trusted messengers, particularly members of the National Medical Association. Our patients trust us, and so we need to make sure that we're giving them trusted, correct information in a timely way. We don't know a lot. We don't know the true mortality rate. We don't know when it will become endemic or not. We don't know fully its effects on pregnant women and fetuses, although at least early evidence is that it doesn't have a major impact. But again, that remains to be seen. And you heard earlier from Dr. Whitney Williams about the children's aspect of this, and we don't understand all of it. But we do know those kids that have been sick. As you heard, many of them may have been young adults and young children that are vaping. And then, of course, the big question of the day is, when do we remove the social distancing and return to normal? Dr. Fauci points out very clearly and succinctly that the virus drives this decision. Having good health and having a good economy are not mutually exclusive. We can have good health, focusing on our health, which will ultimately improve our economy. And we've certainly seen this before. I just remind you that in 1918, a little bit over 100 years ago, we had another such virus that ravaged the world. At that time, we didn't have a vaccine. We didn't have antiviral agents. In fact, most of us didn't even know viruses existed. We survived this. So as a nation, we will get through this. It's going to require more diligence, more coordination, a lot more leadership at the national level. And we physicians, particularly those members of the National Medical Association, we play an essential role in making sure that happens. And this is a list of resources, and thank you very, very much.
Thank you very much for your information, Dr. Benjamin. We look forward to you addressing any questions that we will be getting. And it was excellent seeing this information that has basically been fragmented from different sources being brought together the way that you did. Our final presenter is Dr. Sonia Hutchins. She will present from a health and wellness perspective during the public health crisis. I will just have an aside unrelated to what I'm saying with her. This webinar will go over 1 hour. So please hang on. It's excellent information. Dr. Sonia Hutchins is currently the director of the Public Health and Preventive Medicine Residency Program at Morehouse School of Medicine, where she is also professor in the Department of Community Health and Preventive Medicine. Dr. Hutchins retired as a captain/medical director from the U.S. Public Health Service and CDC after 30 years of service. Of course, again, there's much more to her CV, but we will now move directly into her presentation. Dr. Hutchins.
Thank you. Good morning or good afternoon, everyone. I want to thank the NMA for inviting me and giving me the opportunity to discuss optimizing health during community social distancing.
Dr. Hutchins, speak up a little bit. It's a little, I can't hear you as well as I would like to.
Okay.
That's much better.
Okay. I would also like to thank the National Medical Association for hosting this very important webinar on COVID-19. Given that NMA members provide medical care to to patients who are among the most vulnerable in our society. And Surgeon General Adams spoke to that. These are patients with an increased risk for severe COVID-19 disease because of being at risk, at higher or disproportionately at higher risk of underlying health conditions and socioeconomic, cultural, educational, and linguistic barriers to the adoption of pandemic interventions, such as social distancing, because of limited resources. I heard this morning about the passage of the CARES Act and the relief bill, which has the potential to address the economic needs of the most economically vulnerable population. The objective of this presentation, again, is to really understand how we, as providers and as a part of a family, can advise not only our patients, but our family members and ourselves, that what we can do to optimize our health by applying lifestyle medicine as a major tool to do this. And what are those tools? There are 6 key elements of lifestyle medicine to optimize our health. And this information comes from the American College of Preventive Medicine, their lifestyle medicine course, which is available on the American College of Preventive Medicine's website, and it's cited at the bottom of this slide. These are the key elements: nutrition and diet, physical activity, sleep, emotional well-being, tobacco cessation, and moderate alcohol use. All of these key elements are evidence-based in improving health, and the science, again, is located on the American College of Preventive Medicine website. Let's look at nutrition. We know that what we eat every day affects our health. There are the American College of Preventive Medicine promotes a whole food, plant-based diet, which can be customized based on underlying medical conditions. Whole foods mean not processed, and that means essentially food is eaten the way that it comes out off a tree or out of the ground. Plant-based means the calories come from vegetables, fruits, whole grains, legumes, nuts, and seeds. This nutrient-dense diet has enormous health benefits. These health benefits include the prevention and limit of progression of chronic diseases such as coronary artery disease, hypertension, and diabetes. Now, we know that our patients, ourselves, and family members cannot become vegetarians overnight, but we can follow the dietary guidelines published by the Department of Health and Human Services and the U.S. Department of Agriculture. To eat more than half of your plate at meals to be fruits and vegetables, as seen on the slide to your right, as my plate is the example. Some vegetables that we should be eating, because we should be eating a variety of different vegetables, should be dark green, red, and orange, legumes, beans and peas, and starchy vegetables. We should be eating whole fruits, and these fruits, because we are still in the influenza season, should be high in vitamin C, such as oranges, lemons, and strawberries. With regards to physical activity, we should be following the physical activity guidelines for Americans, which for children includes children 6 to 17 years of age, includes aerobic, muscle strengthening, bone strengthening activities, and for adults, aerobic and muscle strengthening activities. You can see for children what that is under aerobic exercise is 60 minutes of moderate or vigorous intensity daily activity including vigorous intensity 3 or more days a week. For muscle strengthening and bone strengthening activities, the activity should be at least 3 days a week. Among adults, what is recommended is 150 to 300 minutes a week of moderate intensity, and that's essentially at least a brisk walk. And if you do 30 minutes a day, that would add up to the 150 minutes. If you did 60 minutes a day, that would be more like 300 minutes. Or you can spend 75 to 100 minutes a week of vigorous intensity physical activity like cycling or running, or an equivalent of a combination of both moderate and vigorous intensity activity. Adults should also be participating in muscle strengthening activities 2 times per week of moderate or greater intensity. With regards to sleep, the optimal number of hours of sleep is 7 to 8 hours per night. Short sleep is a problem, and that's less than 6 hours per night. And what has been found in the science is that impaired sleep quality and short duration is linked to increased cortisol levels, glucose levels, increased blood pressure, and hsCRP concentration. So all those are problems. Also, it's associated and linked to decreased peripheral blood perfusion and insulin sensitivity, which is why we have, diabetes and cardiovascular disease. We should stay emotionally well during this period, although it's challenging. Here are some examples of how to do that: self-management of mental health and stress through mindfulness techniques, meditation, spiritual and religious activities, relaxation exercises, yoga, tai chi, and time in nature. We should also stay social connected, maybe not in person with the social distancing interventions, but we could stay connected and still maintain our social support via the telephone, through online opportunities and apps. Just wanted to remind us that while this period of social distancing is occurring, some of my colleagues are working and still working with their patients virtually through the telephone and through telemedicine. And I wanted to remind you that we do need to take care of those who are smokers, and to remind them that it's very important for them to stop or quit smoking, particularly during this period where tobacco smoke weakens the immune system, and that we should continue using the 5 A's where we ask about tobacco use, we advise our patients to quit, assess their willingness to quit, assist in their quit attempt, and arrange follow-up, and continue counseling them and treating them with medication if needed for their nicotine dependence. We also should be sharing quit lines where the counseling can occur. And I listed the national quit line number there, but there are state numbers as well. You could check your state and their apps. The last element is alcohol use. And what is being recommended is the dietary guidelines for Americans' level of alcohol use. Now, the dietary guidelines for Americans does not recommend individuals who do not drink alcohol to start drinking for any reason. If alcohol is consumed, it should be in moderation for adults, and that's 1 drink per day for women and up to 2 drinks per day for men. And again, with alcohol, we should be avoiding or counseling about avoiding risky alcohol use. Men, that's greater than 4 drinks per day and greater than 14 drinks per week. And for women, that's greater than 3 drinks per day and greater than 7 drinks per week. And continue to identify persons who are at risk or who actually have the alcohol use disorder and refer them for treatment or treat them. So again, these are the 6 key elements of lifestyle medicine for optimal health, to stay healthy during the season, and in addition to the infection and prevention and control activities. If we follow the advice and focus on these key elements, we should be, as Surgeon General said, resistant to infection or even severe infection. So thank you very much for your attention and the opportunity.
Thank you very much, Dr. Hutchins, for your presentation. We all need advice on how to stay healthy beyond not getting sick, but have optimal health. All right, so we will now move into our Q&A. A number of questions have been sent in. I will not be able to answer them all, if the panelists not be able to answer them all. First question is for Dr. Patricia Whitley-Williams. Are people on ACE inhibitors at greater risk? Are ARBs safer than ACE inhibitors? And should we take our patients off of ACE inhibitors? And you may be on mute, Dr. Patricia Whitley-Williams, so if you are, please come off.
Yes, thank you for that question. This is a question that's being considered. The current recommendations is not to automatically take people off their ACE inhibitors. It is a case-by-case discussion. There is some early evidence that patients who are on ACE inhibitors may have a more severe or worse outcome than those patients who are not on ACE inhibitors. But what we do not want to have is people whose hypertension is being controlled successfully with ACE inhibitors to all of a sudden stop them. It should be an individual case-by-case decision. There's a lot of work being done trying to figure out what role the ACE inhibitor receptor plays in this viral infection. So again, a case-by-case, in some situations, I know in our patients, there was a discussion with the cardiologist or with their private physician whether they should discontinue the ACE inhibitor. But I think the question still needs to be answered. And again, it's one of these risk-benefit questions where you wouldn't want someone to stroke out because they stopped their ACE inhibitors.
Mm-hmm. Okay, thank you very much. Next question is for Dr. Benjamin. I'm going to pull two questions into one. Once testing is more available and instant, wouldn't it be important to test everyone to determine that they're asymptomatic carriers? And coordinated contact tracing, how effective is the current approach if it's not widespread? So kind of tying in contact tracing and widespread testing.
So we do need to clearly do more widespread testing. But let's recognize that there are really two tracks that we need to certainly be on. On the clinical side, it's going to be very, very important to obviously use it for patients who have symptoms to differentiate the disease, coronavirus 19, from something else. And all of us who practice medicine know you've got to try to get the right diagnosis because the therapy would be quite different, particularly in a patient who has pneumonia, or all of us have had to take care of that patient. We're not quite sure how much of that is congestive heart failure, how much of that is pneumonia. You're really going to need to know. So for patients that are critically ill or symptomatic, that's going to be important. Also, as a screening tool for symptomatic medical and health workers, that's going to be an important tool. And we need to make sure that's universally available for all of those folks as a top priority. And then the question, of course, is when do you screen a patient who has basically upper respiratory symptoms, doesn't look too sick, and like anything else, the decision is at least at this point whether or not they have the disease, because you're going to be asking them to distance or isolate themselves for 14 days, which is a pretty long time. And remembering that this initial test we're doing now measures live virus. The assumption is that they have the live virus, they're therefore infectious. And until we get a different understanding of at least the current tests we're doing, we're going to have to assume all those patients that are positive are infectious. So the medical solution, obviously, in a public health perspective, is to test them so that you can decide that you want to isolate them. If it turns out they're negative, they may have something else, and they probably still, for a variety of reasons, as you heard the Surgeon General said, need to at least not be actively exposing themselves to others, because whatever they have is probably infectious, and they need to, even though they may not have COVID-19. Also know there are false positives and false negatives, as you know, with any test. And so you may have to, when we have an abundance of testing, retest them to make sure they truly didn't have COVID-19. And then there's the track that, of course, we're doing in public health, which we're doing from a surveillance perspective. And there's going to be a whole lot of strategies. Strategy number one is doing ring testing around people who may be impacted to find out who is and who isn't, so that we can get some of those people back to work. And then there'll be a broader surveillance activity to kind of test people like we do with the influenza, to know whether it's in your community, where it's in the community. And I think that strategy will be more effective as we begin to try to think about how we reopen our society. Now, that's with the current tests we're using now. Remember that the next test is going to be a bunch of antibody tests. And those antibody tests are going to tell who was exposed, and we hope, again, hope is the key word, who is immune. And if those tests indeed tell us that you had the test and we now know that you're immune but you're no longer infectious, then that would be very helpful to have a much broader strategy to make sure that just about everybody gets that test at some point, so we can, again, reopen our society quicker.
Thank you very much for that response, Dr. Benjamin. The next question is for Dr. Hutchins. We have a lot of those that are now sheltered in place, safer at home. Can you give any tips on exercise in the home, or general, what should people be doing at home? What can people be doing at home when they really can't go out, or can they go out for exercise?
Right. Both for adults in particular, both the aerobic and the muscle strengthening activities can be done, at home. For aerobic, you can walk around your apartment. You can walk up and down the steps if there's steps for 30 minutes. If you can, walk up and down the steps. For children, obviously, they can run up and down the steps and walk around the house. So for the muscle strengthening, it's really resistance. You could take if you have any elastic bands, and you might be able to tie them together so that you can do the resistance part, which is 2 days, 2 to 3 days a week for both.
We can't hear you as well again. Please come closer to the mic.
Children. So there are ways to be creative. What I would say is that if we could provide the link for the guidelines for both for children and adults, and I can send that to you so that you can provide that, and they have more description about the types of aerobic, muscle strengthening, and bone strengthening exercises that can be done to meet those requirements. I don't know whether anyone had the opportunity to look at those in the past, but they are very well done documents with a lot of great information, both on the physical activity side as well as nutrition and diet.
Okay, thank you very much. So next question is for Dr. Whitley Williams and or any of the panelists, but probably she. How long will we deal with this, or do we expect a reemergence in the fall? Kind of a tough question, but people are really concerned about that.
Yeah, I probably should let Dr. Benjamin answer this, but
Certainly.
my understanding is that obviously we're waiting or anticipating that there will be a flattening of the curve, but we do anticipate a second wave. Um, think about what's happening now. We are seeing the numbers jumping not only in New York City, but in Louisiana, in Florida, and in Michigan, so forth. It will slowly work its way, I suspect, across the country, but we do anticipate a second wave. And I'll stop there. Dr. Benjamin, do you have anything?
Yeah, let me reiterate that. We don't know for sure, but Dr. Hutchinson is absolutely right. And we're seeing an increase in the southern hemisphere. What that really means, we don't know, but I think we ought to brace that this will at least become endemic. Again, we don't know for sure. And if that happens, then it may develop some seasonality. But there's so much we don't know yet. So I think from an emergency preparedness perspective, let's prepare for it and hope that it doesn't happen.
I'm going to throw this out to any of the three that I've been getting this. Can you give us in like just 1 minute, the unique experience of African American physicians as relates to COVID-19 in this particular pandemic? And anyone can start with that.
Hi, this is Georges again. I've talked to my colleagues who are public health practitioners who are of color and who are having to deal with this. Dr. Kilowak, who is the health officer in Milwaukee, where half of her patients are African Americans, mostly men, and she's challenged. And I'm watching my colleagues in Detroit who are dealing with this outbreak. This is a big challenge for those people of color who are in policy making positions. And we're having to make sure that people understand specifically the needs of vulnerable populations.
Okay.
So well taken. Spoken. This is Dr. Whitley Williams. I also recently spoke with Dr. Virginia Kane, who is the health commissioner, Marion County, which is Indianapolis, and dealing with some very tough issues. She's also a member of the NMA, African American physician, ID trained. And again, reaching out to physicians of color, many of whom take care of large numbers of African American patients. And it's important that we as physicians, especially those who are out there on the front line, be knowledgeable about this COVID-19 and try to make sure our patients are well informed. It's something we've done in our own at our own university, trying to make sure. I work with a special population, patients with HIV. A number of our children are transitioning adults, and if any time they need to be complying with medications, this is a time. But what's interesting, I think we will have to wait and see. We're not seeing an increase in COVID infections, and this is anecdotal, obviously, in our HIV population. It's very interesting, and whether some of the antiretrovirals they are on that is protecting them, or as they've been instructed, they're staying, indoors, or at least quarantining, themselves away from the general public, other than to go maybe take a walk outside. They're being extra careful, but we've not seen an increase. But obviously, we don't know, and we have to wait until the data is available. But I think as providers in communities of color, the best thing we can do is educate ourselves, and then make sure our staff is educated, and then make sure we are educating our patients, whether it's through conference calls or social media or whatever. Some of our physicians are very unique in how they communicate with their patients.
Thank you.
Yeah, and I'd like to add, my colleagues at Morehouse School of Medicine are taking care of, patients that have many different underlying health conditions. So they have comorbidities, and they're at very, very high risk for severe disease. At the Grady County Hospital, there are a lot of people coming in very, very sick with COVID-19. With regards to the outpatients, they are working diligently to make sure that they have the adequate medications through refilling their medications electronically, and also educating them, as Dr. Whitley Williams said, about social distancing as well, because again, they have many different underlying health conditions. And so we are working diligently with them. On the trainee side, with residents, we are making sure that they also know through their program directors how they can stay healthy while they're taking care of these very sick patients.
All right, well, thank you very much, all three. So we will have to stop here. I have a number of questions that I didn't answer, and we will look to perhaps find a way to answer those questions for you all in an open forum. On behalf of the NMA, I would like to thank you for your attendance in this webinar. This has been recorded and will be archived. Some of the slides will be made available. We'll do as best as we can to have those available to you. Before I close, I must give thanks to a few individuals. First and foremost, our presenters, the Surgeon General, Dr. Jerome Adams, Dr. Whitley Williams, Dr. Benjamin, and Dr. Hutchins. I appreciate your time and effort to present this information on behalf of the NMA. I'd also like to thank Dr. Virginia Kane, Director and CEO, Marion County Public Health Department in Indianapolis, for helping me pull together this preeminent panel, including the Surgeon General. Thank you, Virginia. I'd like to thank Vinay Lobos of Healthcare AV for managing this webinar. And lastly, but not least, I'd like to thank the NMA staff for their tireless support, including Lisa White, Colin Syfax, and Yolanda Swimming. For more information on COVID-19, you may go to our website, nma.org, and there are a noted number of resources. In closing, I'll reiterate what I stated in my opening words. There is life after a disaster such as COVID-19. We are a resilient people. Our sole purpose as healthcare providers and citizens is to reduce or mitigate the damage from COVID-19 and heal the scars that will inevitably be present after this ends. I will add one more task. We must take care of ourselves. Check in with yourself in whatever manner you do this. Faith is a currency during days of stress. We are building a plane while flying it. Everyone, please stay or get well. Thank you very much. This webinar is formally adjourned.